This is Chapter 55 out of your Lewis text. This is Nursing Management of the Male with Reproductive Problems. So we're going to start off by talking about problems of the prostate. So benign prostatic hyperplasia, this is also called BPH, is what you'll hear in practice. And what this is, it's when the prostate will become enlarged. It's a benign problem, and it's actually really, really common, and especially as the patient ages is when they'll have the most problems. So what this will look like is the patient will complain of urinary retention. So they'll also have a weak urine stream. So some urgency, some frequency, difficulty getting that stream going. The complications is that it can cause urinary tract infection. So how they'll diagnose this is the physician will do a digital rectal exam. So they'll feel the prostate and make sure that it's smooth, assess the size of it, if it's firm. And then they'll draw a PSA level. This is also called a prostate-specific antigen. And the normal level of PSA is 0 to 4. Now, the patient with BPH shouldn't have an elevated prostate level unless if there is like a prostate cancer. And so this is used as a rule-out test. But if the patient has like an abnormal PSA and an abnormal digital rectal exam, they'll do what we call a transrectal ultrasound. And that, again, just evaluates the size of the prostate. It's more conclusive than just a DRE. So how they'll treat this is they could do drug therapy. There's a couple different medications they can use. They can use a medication called Proscar, and again, that just enables the urinary stream to start again. But with Proscar, you have to inform the patient that it could take up to 6 months to start working. And another potential side effect is that it can decrease sexual libido. You should, just as a nurse, remember that if you are pregnant, you should not be handling Proscar tablets. They can use Flomax is another one. And again, that just enables, it shrinks the prostate, so it enables urinary flow. An alternative therapy is saw palmetto, but there's really, there's some studies supporting it, but really not enough evidence. So it's good just as a supplemental with another medication, but it shouldn't be the main treatment. They can do other therapies that will be minimally invasive would be like the transurethral microwave thermotherapy, and that just uses heat to kill the tissues. The transurethral needle ablation is kind of the same thing, except for it uses low wave radiofrequency heat. They could use the laser prostatectomy, and that's just a laser beam that causes necrosis of the tissue, so that tissue will die off. Or they can use stents, but the problem with stents is that it can cause pain and infection. They also can do a surgical treatment called transurethral resection of the prostate. You'll often hear it called TURP in practice. And what TURP does is it takes off some of that prostate tissue, basically kind of like shaving down the prostate. And this is the gold standard treatment, and really you'll see it common in practice, especially if you work on a surgical floor or with a urologist. So before the treatment, you want to, if the patient's on blood thinner, they need to hold it for 7 to 10 days. It's up to the discretion of the surgeon. You'll want to teach the patient to avoid alcohol and caffeine, do the time voiding, so every 2 to 3 hours. So then during the TURP, or after the TURP, the patient will have what we call a Coude catheter. It's just a different brand of catheter. And then they'll do what we call continuous bladder irrigation. So they'll continuously having fluid running through the catheter. We want their output to be light pink to clear. If they have deep, like red cherry, it could indicate a hemorrhage, or that your bladder irrigation is not running fast enough, or that there might be a clot. So what you do if there's a clot, the patient will complain of a lot of times bladder spasms. They'll have some pain in their bladder, and you'll see a little bit of leakage from the catheter. So what you'll do is you'll draw up usually about 40 to 60 mLs of sterile or of normal saline, and then you have to manually irrigate to try to get those clots out. And once that clot is out, then the patient won't have those bladder spasms anymore. So after the patient goes home or at discharge, you'll want to teach them that it's normal. Well, first of all, they will be going home with a catheter. So you'll want to teach catheter care, teach them or inform them that they need to be drinking 2,000 to 3,000 milliliters of fluid a day. They need to avoid heavy lifting. So then after they remove the catheter, it's normal to have some incontinence after the TURP for actually several weeks. And so you really want to make that patient aware of that, because they might want to wear like a protective pad, or depends, until they can urinate again. The patient might have what we call retrograde ejaculation. So that's when they ejaculate, some of the sperm kind of goes back in their bladder, and so then when they urinate, it's going to be cloudy because there's going to be semen present. But they should have no problems with erectile dysfunction after a TURP. And here's just a picture. So nursing assessment, you want to ask them about their urine stream. Again, if they've had the TURP, monitoring that continuous catheter irrigation, because again, that's going to prevent the catheter from becoming obstructed post-surgically, and you're going to want to monitor what their urine output is. Again, manually irrigating if the patient's having bladder spasms, because that could indicate a clot. So some nursing diagnoses: impaired urinary function, impaired urinary elimination, pain. And our goal is that we want our patient to be functionable and return to normal urinary function. So prostate cancer, and this is a malignant tumor of the prostate. There's tons of different things that could cause it. age, so the older a man gets, the higher risk he has for developing it. Family history, African Americans have a higher incidence. So some of the, early on there's not a whole lot of clinical manifestations, but later they'll have symptoms of like dysuria, dribbling, nocturia, hematuria. So a lot of times, you know, it kind of mimics like a UTI. There's just a x-ray of what metastasis would look like to the pelvis and the spine. So diagnostics, again, they'll do that DRE, that digital rectal examination, and then they'll take a PSA level. And I mentioned before the normal is 0 to 4, so they're going to have an elevated PSA level. And the nice thing about PSA is that it's not only used to detect cancer, but they use it to monitor the treatment of cancer. So once the patient has started like a chemotherapy or radiation, then they can do those levels to see if it's been effective. So conservative therapy, they might just watch it and just see if there's any complications or problems or growth. Surgical therapy, they could do a radical prostatectomy, and that's where they remove the prostate, they remove the seminal vesicles, and then parts of the bladder. They can do a nerve sparing procedure, and that's when they do that removal, they'll try to preserve the nerves that help with erection, because once you take those nerves out, then there'll be an erectile dysfunction. They can do cryotherapy, and this destroys the cancer through freezing the cells. Then they can do, again with radiation therapy, they can do like a brachytherapy where they put in an implant right in the prostate, or they could just use radiation to destroy that cancerous tissue. They can use different hormonal therapies, chemotherapy, orchiectomy, but your job is really to make sure that the patient is going in for regular screenings, especially when they're on chemo, because chemo, remember, chemo immunosuppresses, and so a lot of times people will develop other cancers from having chemotherapy. So making sure that the patient's doing regular cancer screenings. You're going to want to promote comfort with chemotherapy, try to control their pain. So nursing management, nursing assessment, again, assessing the pain, vitals, finding out how their urinary stream, making sure again that they're doing that follow-up, diagnoses, acute pain, urinary retention, impaired urinary elimination. You're going to want to offer support, tell them to increase their fluids, monitor for signs and symptoms of UTI, comfort. Prostatitis. This is an inflammatory or non-inflammatory condition that affects the prostate. Again, the clinical manifestations, they'll have urinary tract-like symptoms, but the complications that can arise from this is like a cystitis or a post-ejaculation pain. So diagnostics, they'll do a UA and a WBC. Treatment will be antibiotics, Bactrim, such as Bactrim Cipro. You want to tell the patient to increase their fluid intake. They may need prostate massages. If they have a high fever or become septic, then they'll need IV antibiotics. Sometimes when they have that really bad urinary retention, they'll need a catheter, but it has to be a suprapubic catheter because Foley catheters are contraindicated because the patient will have all that swelling. So problems of the penis. So congenital problems will be like hypospadias, and this is where the urinary meatus is on the ventral surface. And the problem with this is when the patient has an erection, they can have a downward curvature of their penis, and it's really, really painful. They can have epispadias, and that's where the urinary meatus opening is on the dorsal side. They can have phimosis, and this is where there's a constriction of the foreskin around the penis, so they can't retract that foreskin. You just really want to teach good hygiene. Or they can have paraphimosis, where they can't retract it back at all. So these patients will have to be on antibiotics, have a circumcision, warm pack around their penis. They can have problems with the erectile mechanism, and this is a condition called priapism. And what it is, it's a painful erection that lasts longer than 6 hours. And this is an emergency because that lasting erection can cause hydronephrosis or tissue necrosis. So again, teaching the patients that, if they have an erection that's lasting more than 3 hours, they need to come in for treatment. So cancer of the penis. This is associated with the human papillovirus, so HPV, and it's also been associated with men that were not circumcised as infants. The treatment is if they catch it early enough, they can do a laser treatment, or if it's late, they'll have to do a radical penile resection. Problems of the scrotum and testes. So the patient can have epididymis, and this is when there's an inflammation of the epididymis, and it's unilateral. It's related to an STD or trauma, and the treatment's going to be bed rest. They're going to elevate that scrotum and put ice packs on the scrotum. Orchitis. This is related to exposure to mumps, and again, it's that inflammation of the testes. So to treat it, they'll give antibiotics, and again, that bed rest with elevation of the scrotum, and then ice packs. So congenital problems. Cryptorchidism is where the testes don't descend, so they have to do surgery. Hydrocele is where there's a non-tender fluid filled mass in the testes, and what they'll do is they'll shine a flashlight through it, and if it transilluminates, then it's that hydrocele. They usually don't treat it unless if the hydrocele is causing problems, and then usually they'll just drain it surgically. That would probably be a problem. Spermatocele, that's where there's a firm painless cyst, and they'll treat it through surgery. Varicocele, that's where there's a dilation of the veins in the testes. Again, they'll do a surgery. Testicular torsion, that's where there's twisting of the spermatic cord. And this is a surgical emergency because if it's not corrected in 4 to 6 hours, it causes ischemia of the testes. Testicular cancer, that is a scrotal mass. The patient will complain of a heavy sensation in their abdomen, in their peri area, or their scrotum. So diagnostics, they'll do ultrasound. They'll do blood work. They'll draw an alpha-fetoprotein level, HCG level, an LDH level. They could do a CT or chest X-ray to look for any metastasis. So what we can do to promote health is to promote testicular self-examination. And so they're going to want to do that in the shower at least once a month, kind of like women do their breast exam in the shower once a month. But oftentimes it's actually the partner that finds it, because they're the ones that will feel the breasts or feel the testes and know what that patient's normal is. So for collaborative care, they can do surgery where they remove the testes, spermatic cord, and regional lymph nodes. They'll do chemo. This patient will be infertile, and a lot of times they'll have an ejaculatory dysfunction. So sexual functioning. A vasectomy, this is a surgical ligation to make men sterile. It's a pretty simple procedure. It's same day, right in the doctor's office. It's less painful for men to go through than the women having to get their tubes tied. So post-vasectomy, you're going to want to teach the patient to use other birth control methods for 6 weeks. Monitor the incision for signs and symptoms of infection. Erectile dysfunction. This is an inability to attain or maintain erection. So there's a whole lot of different causes. Alcohol and drugs are one. So, teach if they want to maintain a healthy sex life. Probably alcohol and drugs aren't a good choice. So diagnostic studies, they'll do hormone levels, the digital rectal examination, they can do vascular studies. So to treat it, they can do oral drug therapy. This would be like Viagra, Cialis. I'm sure everybody's seen commercials for those. They can use a vacuum device, and that just kind of pulls all the blood up into the penis. They can use an intraurethral device, penile implants, and then sexual counseling. Now, the oral drug therapy, so like the Viagra, Cialis, teach the patient that if they're on nitrates, they should not take this because it could cause hypotension. So again, to educate the patient, tell them to avoid drugs or alcohol because, again, it can cause difficulty in getting or maintaining that erection. You want to reassure the patient. Sometimes this is really embarrassing for the patient to talk about. They may not feel as manly. Andropause. This is where there's a decline in androgen. So it causes a decreased libido. It causes erectile dysfunction. So they'll use testosterone replacement therapy. But you have to make sure that you talk to the patient before they start this and ask them about their urine stream, making sure that they're not having symptoms of BPH, because it's contraindicated in patients that have BPH or prostate cancer. Infertility. This is where the couple is having unprotected sexual intercourse and it has been unsuccessful in getting the woman pregnant. But the couple has to be trying for more than 1 year. So it could be factors affecting the woman, or it could be factors affecting the man. So we'll do sperm studies. Again, for this patient, make sure that you're offering a lot of support because it's really emotionally hard for a couple that's trying to get pregnant.